Good morning. Thank you very much for the invitation. I'm going to speak this morning on the role of renal function in acute heart failure. This is the classification and definition of the cardiorenal syndrome proposed by Aronson and the co-authors. This morning I'm going to talk on the type 1 cardiorenal syndrome, which is defined as an abrupt worsening of cardiac function in association with acute kidney injury. In terms of the prevalence and clinical significance of the cardiorenal syndrome, I would like to show just one slide from a recent paper by Kevin Daman in the European Heart Journal. It's a meta-analysis of many studies looking both at chronic kidney disease and worsening renal function. Over 1 million patients in studies that looked at CKD and about 50,000 patients in studies looking at worsening renal function. The prevalence of chronic kidney disease was 30% and was associated with increased all-cause mortality with an odds ratio of 2.3. Worsening renal function was present in more than 20% of patients and also was associated with increased mortality risk with an odds ratio of 1.8. So it's a very common problem and associated with increased mortality. The pathogenesis of the cardiorenal syndrome is very complex and includes decreased cardiac output, arterial antifilling leading to intense neuronal activation, and also increased preload leading to venous congestion and increased intra-abdominal hypertension, and this leads to vasoconstriction in the kidneys, decreased kidney perfusion, and on top of this we also have therapies that we use in acute heart failure that may contribute to renal dysfunction, and also the background diseases of the patients, hypertension, diabetes, and so on. Recently, there was a lot of attention in the issue of venous hypertension, venous congestion, and also increased intra-abdominal hypertension. We saw the previous patient that was presented by Dr. Delgado who had a CVP of 25. Both venous congestion and intra-abdominal hypertension will cause increase in tubular hydrostatic pressure, which will oppose filtration and also increase interstitial and renal vein pressures, and this will lead basically to increase in the proximal tubular pressure and increase the filtration function, and potentially will lead to worsening of renal function. We tried to look at this in a study where patients, about 240 patients, were with one gas treatment with diuretics and vasodilators. And you can see here it's a bit complicated graph, but you can see here the change in right atrial pressure, and here patients in red dots represent patients who develop worsening renal function. The green dots show patients who did not develop worsening renal function, and you can see that there is really no relationship between the reduction in right atrial pressure and the risk of developing a worsening renal function. So we couldn't really show that if we decrease the right atrial pressure during treatment of acute heart failure, we can prevent worsening of renal function. This is a relatively recent study from the Cleveland Clinic looking at intra-abdominal pressure. You can see here a direct relationship between serum creatinine and intra-abdominal pressure measured through a urinary catheter, which lead to the fascinating hypothesis that if you can decrease the intra-abdominal pressure, we can improve renal function, as I showed in the slide previously. This data is from Zaid Abbasi's lab. We looked at in a rat model of heart failure, what was the effect of gradually increasing the intra-abdominal pressure, where we can actually control it very precisely. And you can see that when we increase the intra-abdominal pressure to 10 and 14, which is actually quite elevated, we see a quick reduction in the GFR and in the renal plasma flow. So it's a very interesting hypothesis, and the mechanism for worsening renal function in acute heart failure. And the clinic group actually showed that many patients without frank ascites may have intra-abdominal hypertension, and this may contribute to the renal dysfunction. Usually, when we treat patients with acute heart failure, as we saw in the previous lecture, we give them vasodilators or inotropes, and we hope that the improvement in the cardiac function, the increase in cardiac output, will also improve renal function. But there's also recently attempts to actually target the kidneys to enhance the congestion and preserve renal function, and this is considered under the title of renal adjuvant therapy for acute decompensated heart failure. The first study that actually tried to do this was the PROTECT study, which used the Rolofylline and Adenosine A1 receptor antagonist, which had multiple effects on the proximal tubules and the GFR. This was thought to be a good idea to preserve renal function and to enhance diuresis, but as you can see here, there was no difference between Rolofylline or placebo in terms of change in creatinine and also in PUN, and the outcome of these patients at 60 days was similar to placebo. In the more recent acute heart failure study, patients were randomized to Nesiritide, low-dose Nesiritide strategy, or Dopamine strategy, and within each group, in the Nesiritide group, randomized again to low-dose Nesiritide or placebo, and in the Dopamine group to low-dose Dopamine or placebo. And all the patients received the standardized running dose that was about 2.5 times the outpatient furosemide equivalent, similar to the dose study. Unfortunately, if we look at the low-dose dopamine strategies, there was no difference in the co-primary endpoint of 72-hour urine volume or changes in cystatin C, and no difference in clinical outcomes in terms of hospitalization for heart failure or mortality. Similarly, in the low-dose Nesiritide, the co-primary endpoint was negative, no difference in 72 hours volume, urine volume, or change in cystatin C, and again, no difference in the hospitalizations for heart failure or mortality. The CARRESS heart failure study was also mentioned earlier. I'm going to go very quickly on it, but basically ultrafiltration was used versus medical therapy, step pharmacological approach, and the patients were managed in an attempt to achieve clinical congestion, which was defined as JVP less than 8, and no more than trace peripheral edema and lack of orthopnea. As we saw earlier, there was no difference in the co-primary endpoint. The weight loss was similar in both groups, but there was some worsening in creatinine in the ultrafiltration group, and this was a reason to stop the study, also because of futility and because of the complications that were mentioned earlier. We saw that the previous patient was presented was swine gun, the catheter was used, This was also looked at in a sub-study of the escape study, where patients were randomized to receive a pulmonary artery catheter or to be managed without it. And you can see here that even if you manage the patient with a pulmonary artery catheter in an attempt to understand the hemodynamics, to measure the cardiac output, to know what the CDP is, to measure pulmonary pressures, you cannot prevent worsening of renal function. It's not superior to clinical management at all. When we treat patients with acute heart failure who are congested, there's always a sort of a tension because we know we must decongest the patient, but we're always also worried about the renal function. This is a slide showing that in a large registry in the United States, that about 50% of acute heart failure patients are discharged from hospital with weight gain or losing less than 5 pounds. And this is also true in the very, very recent clinical trials that were done in excellent centers, a post-hoc analysis of the dose heart failure in the CARRESS studies show that about more than 80% of patients were defined as moderate or severe congestions. Following aggressive inpatient therapy, targeting the congestion with a very clear, strict protocol, more than 1/3 of patients were actually discharged with moderate or severe congestion. And higher congestion was associated with increased 60-day mortality and rehospitalizations. We also need decongestion not only to prevent rehospitalization and mortality, but also to improve dyspnea. This is from a hemodynamic study that we did, and you can see here the probability of the patient reporting on the light of a moderate or marked improvement in dyspnea. And you can see that the probability of the patient improving in terms of dyspnea increases in almost a linear fashion as you are decreasing the wedge pressure. So we need to decongest the patient, but at the same time, we're worried about renal function. When we transiently remove fluids from the intravascular space, either by diuretics or ultrafiltration, this triggers a compensatory mechanism that are called plasma intravascular refill. And this is aimed, of course, to recruit fluid from the extravascular space into the intravascular space and prevent hypotension. When all goes well, the rate of diuresis and the removal of plasma from the intravascular space is more or less equal to the removal of edema from the tissue, and then the patient is not going to develop hypotension or worsening renal function. But in clinical practice, the diuretics rate is never titrated to match the plasma refill rate, and therefore may randomly either exceed or remain below the potential maximal plasma refill rate. And if this occurs, the patient may develop hypotension and worsening renal function. This is always a concern when we treat these patients. Dr. Delgado already showed you this slide. The worsening of creatinine compared to medical therapy in the CARRESS study may well have been because of quick removal of intravascular volume in the ultrafiltration arm, and this is also seen in the unload study. We looked at this a few years ago. What is the clinical significance of transient versus persistent worsening renal function? And we observed that the mortality was actually increased only in the subgroups of patients where persistent worsening renal function was transient renal function was not associated with increased mortality. In the UNLOW trial, a trend toward worsening renal function was in greater weight loss with ultrafiltration was associated actually with a reduction in the rate of rehospitalization for heart failure. And in the dose trial, a higher dose of diuretics was superior to the lower dose diuretics for dyspnea relief and fluid loss at the cost of a transient worsening of renal function that did not appear to have any long-term consequences. So transient worsening renal function may be a reasonable trade-off to achieve the congestion and prevent hospitalizations. What is the approach today to worsening renal function and persistent congestion? We don't have really any new exciting treatments. I'm not going to mention relaxing because we have a full lecture on it later this morning. But basically, we need to optimize diuretic dosing. We can use IV furosemide at the dose that is 2.5, the patient's home oral diuretic dose, which generally results in substantial diuretic response and dyspnea relief. We can also add thiazides or mineralocorticoid with receptor antagonists at natriuretic doses. For example, as a protocol that was shown in the earlier lecture of the CARRESS study. We can use vasodilators for hypertensive patients and inotropes. Ultrafiltration based on the data that we have from the CARRESS study, I think we should use with caution because of a sign of increased complications. We saw it also in our institution, but there is a large ongoing study of 800 patients that I hope will give a definite answer with regard to the efficacy of ultrafiltration. Should we consider a renal dose, renal-specific therapy? We have no proven value of renal dose dopamine, Nesiritide, Adenosine antagonists, or vasopressin antagonists, although there are two ongoing studies on tolvaptan. And again, should we put a swan-gun catheter to guide IV therapy to get a better and deeper understanding of the hemodynamics of the patients? There is no evidence that this works. So to conclude, the therapy of patients with cardiorenal syndrome is not evidence-based and remains a clinical challenge. The concept of renal adjuvant therapy remains to be proven. Given the complexity and heterogeneity of this clinical syndrome, it's unclear whether a single agent that acts on a single mechanism can exert a meaningful clinical benefit. In many patients, it's extremely difficult to identify a prominent mechanism that leads to the worsening of renal function, and therefore we treat them in the same way. And the attempt to relieve congestion often involves therapeutic decisions that may seem contradictory, reflecting compromise between potential benefit and harm. Thank you very much for your attention.